the brands that really win and truly help providers and patients, they also don't sit at one fixed point on this care journey. They flex along a spectrum from clinical efficacy, because we know we have to communicate clinical efficacy, to cognitive efficacy based on the decision moment and the audience need.
Care is not just about a messaging model, right? It's a friction reduction model. A quick reference that we like to use is clarity. What happens next? Agency. What can I do? Reassurance. Am I okay to feel this way? And engagement. Did I actually move forward?
Cognitive efficacy is the bridge between accurate information and usable understanding amid overload. Clinical evidence shows what a therapy can do, but cognitive efficacy ensures people understand it, choose it, and follow through in the moments that matter. Hello and welcome to the MM+M podcast. I'm Managing Editor Jack O'Brien. For today's conversation, we're talking about when knowing isn't doing. Instead, we're turning clinical evidence into real-world action. I'm pleased to be joined today by Danielle Cranwell, President and Global Agency Head of Wedgwood Health, along with her colleague Keith Testa, EVP of Creative and Innovation. Danielle and Keith, it's wonderful to have you on the show. How are you doing today?
Good. Thank you for having us.
Thank you. Thanks for having us.
I appreciate you both being on here. Looking forward to the conversation. Let's start with the big picture. And I think a lot of people are probably having the same question that I have. What is cognitive efficacy? Can you put that in plain terms, and why is it important now?
Sure. Well, a lot of us know that clinical efficacy tells us what a therapy can do, but cognitive efficacy asks whether communications and experiences help someone understand enough to make that confident decision and follow through in the real world. Because the truth is, accurate information is not the same as really usable understanding. So in healthcare, especially in those high-stake moments, that distinction matters a lot.
The simplest way that I like to think about it is that our communications or experiencing help people know what to do next, or are they just giving them more information to process? And that's why it feels timely. Everyone is overloaded. Patients are overloaded. Caregivers are overloaded. Clinicians and office staff are certainly overloaded. So the bar is no longer just, was the information correct? It's, was it actually usable under pressure?
I totally get that. And maybe we can take this a little bit more to the real world effects of stuff. We've all been in the hospital before. We've all accompanied somebody to the hospital. It can be a really high stakes, stressful environment. And I want you to kind of walk me through, and maybe Danielle, you can take the lead on this one in terms of why those moments like a diagnosis or treatment selection, why is it so important to have understanding and get through the fragility of that situation?
Sure. Yeah. In those moments, people are hit with what we call a temporary bandwidth collapse. So it's not about intelligence. It's not about motivation. It's what happens when you have all of these emotions, the consequence, the time pressure, and the system complexity that you're dealing with. They're all colliding at once.
And marketers can miss because we tend to imagine communication is just landing in a clean environment. But it rarely does, right? It lands when someone is scared, when they're rushed, distracted, or interrupted, or even just trying to keep 5 complete thoughts in their head at the same time. That's what makes it difficult.
Yeah. And someone can be nodding along and listening and even asking good questions, a patient, for example, and still really leave that moment without a durable understanding of what's going to happen next. So that's really where this breakdown we've identified occurs.
And so the issue isn't just comprehension, right? It's action readiness. Did the interaction reduce the burden to the next step, or did it add to it?
You're both talking about nodding your head and listening and trying to keep 5 thoughts in your head. I thought you were describing me for a second and the lack of understanding there. But yeah. I think it does apply. It's kind of a universal quality there. I want to ask too, and not to fully jump around in terms of the conversation that we're having, but talk a little bit from a clinician's perspective too, what that overload looks like. I know that I used to cover hospitals and health systems, now covering pharma and biotech. The administrative burden that HCPs are under is well documented and getting worse. It's been one of those things that just hasn't been fully remedied. So what does that look like in terms of the overload in a 20-minute patient visit and then the downstream effects from there?
Yeah. So, I think it looks like compression, right? The clinicians trying to assess, prioritize, educate, document, reassure, and move the visit forward. So there's all these things going on at that same time. And the patient at the same time is trying to absorb what this means, what the options are, what happens next. What does this mean for my life as a patient?
When that much gets compressed into a short time frame, you lose nuance. The conversation shifts toward what's urgent and what's familiar, or what can be explained fastest.
Right. And when that happens, patients leave that experience, they leave that encounter with a partial understanding, or maybe misinterpret instructions or delay actions. I mean, I think we've all had that look at your prescription bottle, and we're, educated people, especially us in this business. And you're looking at it and you're saying, wait, 2 times a day with meal? And you leave with a very, uncertain understanding of what you need to do.
And then what that translates into is then the whole system just pays for it later, right? There's more callbacks, there's more need for clarification, there's more rework, more preventable drop-offs at the end of the day.
And then that lower patient success leads to lower trust, lower satisfaction, and a higher burden on the healthcare provider. So it becomes bigger than a communication issue. Now it's starting to become a real world performance issues. And a lot of physicians are evaluated on their performance.
And I know a physician that you've been in contact with, Danielle. There's an interesting story for our audience that relates to Disney World. Can you walk us through that and kind of illuminate that for the audience?
Yeah, I guess this concept really crystallized for me over the winter. I was in a conversation with a good friend of mine, Dr. Shannon Parks. We were taking our families on vacation to Disney World. You can imagine it was between the Christmas and New Year's time, long lines. We had 4 middle school boys with us, 2 husbands, just loads of people around us. And we were on a really long line and just so much going around. And I was asking her, what's it like for you as a practicing physician? What happens when all of these things in your world, your personal world, as well as your professional world, collide? And then what is that happening for your patients as well? So what's going on in that conversation? So she was describing to me the pressures of her pressures. And she said, my patients have that real everyday pressure as well. And she said something to me that really stayed with me. She said, in those 15 to 20 minute visits that you have, patients sit there and they nod in agreement, but while visibly overwhelmed. She described it as like a real phenomenon that there's this temporary collapse in bandwidth at a diagnosis or at a pivotal treatment moment. And she said, even these highly educated, composed people struggle to remember the basic next steps after a life-changing conversation. And that's when we really started talking about what can brands do to help.
And that's such an important point because it really kind of shifts the frame of reference, right? The problem isn't that people aren't paying attention. The problem is cognitive load under stress.
Mm-hmm. Yeah. And she said, not only are my patients under that, she goes, but I'm under that same similar pressure, decision fatigue. I'm dealing with prior auths, callback volume. There's guideline changes, so many things that she needs to keep up with and she has limited attention for. So the burden becomes shared across the encounter. Not just is it the patient, but it's the provider feeling that burden.
What I'm gathering from this is the happiest place on earth sometimes can be more like the hospital, which is oftentimes for a lot of people the unhappiest place on earth. So it's interesting to kind of draw those parallels there. Talk a little bit, there's this idea of like the CARE lens, and I love any sort of acronym. This one stands for clarity, agency, reassurance, and engagement. Why these elements in this order? Walk me through that.
Great. Well, listen, I love CARE because it does give structure to something that can otherwise just sound really kind of abstract and not pertinent. But it helps us to decide what to communicate, when to communicate, and how to keep that experience consistent across the journey, right? First, clarity. Do I understand what it is and what's up next, right? Second, agency. Do I know what I can do from here? And do I have a manageable next move to make? And then third, reassurance. Are my concerns normal? Are they anticipated? Am I validated? Am I supported? And then the fourth is engagement. We always talk about engagement, but did all of that make a follow-through move likely or just create more obstruction?
Yeah, and the order really matters here. So clarity has to come first, because if I don't understand or you don't understand what is happening, you can't really act. And then agency is next, because people need that next step. They need to actually see themselves taking that next step. And then reassurance is is so important because reassurance without structure can feel really vague, and it lands better once there's some orientation underneath it. And then, of course, engagement is the outcome, right? It's the result of the first three of those things working together. So the brands that really win and truly help providers and patients, they also don't sit at one fixed point on this care journey. They flex along a spectrum from clinical efficacy, because we know we have to communicate clinical efficacy, to cognitive efficacy based on the decision moment and the audience need.
And just one last kind of way to sum it is, so care is not just about a messaging model, right? It's a friction reduction model. A quick reference that we like to use is clarity. What happens next? Agency. What can I do? Reassurance. Am I okay to feel this way? And engagement. Did I actually move forward?
It's good to know that there is a through line in terms of what you're talking about there from one stage to the other. And I don't want to be reductive here, but when you look along the care journey and you think about diagnosis, decision, initiation, and access, early maintenance, et cetera, does cognitive efficacy matter most? Where along that spectrum does it have the biggest impact?
You know, it really matters all along the journey, right? But it shows up differently based on where you are. So at diagnosis, for example, it could be about reducing disorientation. At treatment, it's about comparison without that overload. So comparing one or two therapies and what's the best for you. At initiation and access, it's brutally practical at this point because you're dealing with forms, prior auth, specialty pharmacy scheduling, cost, training, et cetera. And early in the maintenance phase, it's about reducing drift. We often see patients kind of maybe not taking the therapy as prescribed. So having the conversation around side effect management, uncertainty that you might experience, missed refills, disrupted routines, that sort of thing.
And I would say that if I had to pick a pain that is most visible, I'd say in the initiation and access phase. Right. That's where good intent often dies, in the gap between yes and the action of starting.
Yeah, I agree with you, Keith. But diagnosis and decision, I think, are where the tone gets set. So if people leave those moments uncertain, everything downstream gets heavier. So it's really critical there.
I'd love to know, too, like this is something that goes back again to my days of covering hospitals and stuff, is like this idea of like handoffs are where things fail or where things go to die just because there is that lack of communication or coordination. Talk a little bit about the make it easier fixes for each. And I think about it from HCP to staff, staff to pharmacy, pharmacy to patient. Like, where are the fixes along that line?
Well, I would say that you're right. Handoffs fail when information is technically present, but functionally unusable to the audience.
Right. For example, from like HCP to staff, what often fails is that translation. So the decision may be made, but the operational path is fuzzy. So to fix it, we have to simplify the action, make ownership, next steps, and the likely barriers unmistakably clear. And
then from the staff to pharmacy, what often fails is the completeness or exception management, as we call it, right? The easy path is often defined, but the messy path is usually not very well defined. And the fix there is for exceptions, right? What happens if something is rejected, delayed, or incomplete, or even unanswered? How do we correct for that?
Yeah, to make sure we're designing for those exceptions and thinking about it as we're creating the materials. And then we see further breakdown, from pharmacy to patient. What often fails there is this idea of readiness. So the medication might be available, but the patient might still not know what to expect or do next. So things like creating a very practical first 72 hours guide. What happens now? What's to be expected? What matters today? Who to call? So we're really helping them have that clarity there.
The principle behind all of this is really fairly simple, right? Every handoff should answer the question, what am I supposed to do with this now?
Thinking about that as we are creating materials.
And I'm curious, too, for those in our audience who might say, oh, yeah, I want to go and embark on this, but how do I evaluate? What are the keys to being able to evaluate and say, oh, yeah, we're meeting our expectations, or maybe we have to rework here. There's room for improvement. Like, what does that look like?
Yeah, I think I would take a look at the beliefs and the behaviors that you're expecting. So I would say, look there, right? And make sure that your beliefs are aligned, and make sure that the first belief you're seeing is, I want to understand what happens next, because that's really the clearest signal that clarity is there or is improving.
And then I know what I can do from here, right? And does it feel manageable? Does it give me the agency that I need?
Yeah, and then you start to look at the nearest meaningful behavior. So, which would maybe be referral completion or enrollment completion, first fill, time to start, something close enough to the intervention and what you can learn from it.
And the sequence, as Danielle mentioned, it's important, right? Because if beliefs improve, but behavior doesn't, that tells you that something is valuable and that the message can be better and that the system is still too hard.
Mm-hmm. I mean, I think what Keith said is really the answer to your question. If beliefs move, but behavior doesn't, you didn't solve for that friction. You just improved language. You just changed tone.
And at the end of the day, that's more window dressing than anything else. We want to see actual change that has a meaningful impact on patient outcomes and the entire spectrum that we've been talking about. But
Absolutely. It's
been wonderful to have you both on the show. I really appreciate all the insights that you've been able to share here and kind of walking through your thought process. For those in the audience that might be looking for like just a tiny fix that maybe they can implement at their organization tomorrow or in the days to come, what would that be? Danielle, I'll throw it over to you, and then Keith, you can close this out.
Sure. I would say pick one touch point and ask a brutally simple question, which, does this make the next step easier? Not more complete, not more sophisticated, not more on brand, but easier.
And I would say it could be simple as a leave behind or a hub email or even a start form or a script for a nurse, right? Or a workflow sheet, anything that will help ease that process. If it doesn't clearly help someone know what to do next, rewrite it until it does, because that's where this concept becomes useful. Not a theory, but everyday places where people have to get stuck.
And just, if I had to leave like one idea with your listeners, it's this, and because we hear it from marketers so much, exposure to your brand and to your messaging is not understanding. And understanding isn't follow through.
And then, frankly, the brands that will stand out are the ones that do more than communicate accurately. They make action easier under real-world circumstances.
To us, that's cognitive efficacy.
And that's the name of the game right here. I appreciate you both being on the podcast, be able to talk about cognitive efficacy. Danielle, Keith, thank you again. Take care.
Thanks, Jack.
Thank you.